Okay, hi again, everyone. We're going to be starting now. It's noon, my time, that is. My name is Raihanah, and welcome to SCIDaR's webinar on building capacity for development, where we'll be sharing lessons learned from immunization, polio, HIV, and Ebola. I would like to admonish everyone to put their mics on mute and also notify you that we'll be recording this just for our own internal use thereafter. So please bear with us. As I said, my name is Raihanah and I work at SCIDaR. I am an engagement manager at SCIDaR, and I will be facilitating this session together with two of my colleagues, Dr. Muyi Aina and Dr. Uchenna Igbokwe. Hi, Muyi and Uche. Both of them are partners and program directors at SCIDaR, and will be joining me to take us through this conversation today. So before we start, I would just like to highlight the objectives of this session. What we're trying to achieve really is to highlight the role of tailored capacity building interventions in developing resilient and prepared health systems that will help nations or governments handle epidemics, with examples from HIV, immunization, and Ebola. Specifically, we'll be sharing experiences from the work that we've done in development, specifically in health, building the capacity of health systems for the state governments that we work with, and also national, federal governments as well. We'll also be highlighting how we might apply the systems or the lessons that we've learned to the COVID-19 pandemic. As we all know, that is the trending topic now, and this conversation wouldn't be complete without highlighting how we might be responding to COVID better, or how we can share lessons across sectors on how to improve the situation. So before we go ahead, we'll do a quick icebreaker. The comment session is enabled. Please try to use the comment section to indicate where you're joining us from today. Uche and I are in Nigeria, and Muyi is in America right now. He's in the United States. So please use the comment sections to say where you are, and happy to meet you. If you can, also drop what you do and what sector you're working. That would be great as well. Thank you. So I'm just going to let some comments rolling and just chat with everyone before this goes in. So we have someone from Ireland, UK, France. It's really a global meet. South Africa. Hi, Clara, New York. Hi, Dr. La. Yeah, hi everyone. It'd be really great to just hang out there and just continue the chat, but we need to move on now to the content of today's discussion. So I will be describing what we do as SCIDaR, just as a background before we start. SCIDaR stands for Solina Center for International Development and Research. It's a subsidiary of Solina Group, which is really a conglomerate of health systems companies. And what we do at SCIDaR is that who we are at SCIDaR is that we're a private, not-for-profit organization. We work with donors and governments to conceptualize, design, and accelerate sustainable system strengthening interventions in development in Africa. We work across different sectors, health, education, agriculture, and some economic empowerment. But a majority of our portfolio is in the health sector and some also in the education sector. Basically, what we do is that we build capacity of our clients, which are primarily governments. So we have state governments, federal governments as well. We help them to plan for and deliver cost-effective health services to their populations. And the way we do this is that we apply proven business and research methods to our health systems work. And we have principles that are non-negotiable that we work with. We ensure that the government owns it and takes the driver's seat. We also build on existing structures, so we don't go and set up vertical structures unless absolutely necessary. We also try to focus all our work on building capacity rather than filling it. So we believe that to have sustainability or to ensure sustainability, you would require to have capacity built in such a manner that when you leave, the system can still function without your presence. So we have footprints across Africa, predominantly in Nigeria, of course, because SCIDaR is an indigenous company after all. We have footprints across all the states in Nigeria, more in some than others, more in the north than others for many reasons that we'll get into as the conversation goes on. But also in Africa, we have some work that we do in routine immunization strengthening. In 3 countries, we have work that we've done in Guinea-Bissau with their Ministry of Health just to strengthen leadership capacity. And we are also starting some body of work in Africa for polio and trying to ensure that Africa stays polio-free going forward. So I'll move on now to highlight some examples of the work that we do. Our programs span across institutional or organizational strengthening, and those will be things about capacity building, like how we support the primary healthcare boards or the federal ministries of health to, strengthen their systems. But also we do some service delivery work. We have a HIV prevention and control program that we run across 4 states in Nigeria, where we provide technical assistance to private health facilities to offer quality HIV services to clients. This spans from PMTC, HIV testing to prevention of mother-to-child transmission, and so on. On immunization, we've done a lot of work in immunization, but specifically I'll be talking about our flagship immunization work that we've done across 6 northern states in Nigeria. When I say immunization, this also includes polio eradication efforts that we've worked on or that we continue to work on in Borno State, in security compromised states, where we work with the military and the government to deliver potent polio vaccines to children. Outside of polio eradication efforts, for immunization, we also work with 6 state governments and the federal government to strengthen health systems and build capacity of individuals for routine immunization and the broader primary health care in Nigeria. So that said, we work in Africa, and we would say, why Africa? Well, we know that, apart from the fact that we're Africans, of course, we know that Africa is the epicenter of a lot of preventable diseases, a lot of communicable diseases, specifically polio, Ebola, and so many other diseases that Africa is riddled with. We also know that women still die of childbirth in Africa. 1 in 39 women in Africa would die from pregnancy-related complications. And this isn't comparable at all to what we have in more developed countries, where we have about 1 in 5,000 women dying. So ours is way, way, way higher than what you find in developed countries or continents rather. We also have high HIV prevalence. We have severe malnutrition and hunger. We have 41% poverty rates and high rates of illiteracy. Now, I mean, these bad outcomes that we see in Africa are due to certain reasons, and we like to think of them as systemic issues that are quite cross-cutting across all of the areas of development, or at least in the human capital development space. And specifically, these things are absence of enabling policies that will help bring about transformation and sustainability. We have weak governance systems that will help drive political will and continued oversight. We have issues with funding and lack of financial transparency. And then there's just also the issue of poor planning. So you have sometimes no plans at all. And in some cases where you do have plans, it's bogus, the figures are outrageous, the activities are unrealistic, and even when they do get to implement some of them, they just don't track them, or they don't go after them aggressively. And finally, we have one of the biggest components, which is really the lack of competent personnel to drive the processes. So we have situations where all the personnel that work with government do not know what they're doing. They don't know what they're expected to do. They don't have the skills required. There's no enabling environment to help them do their jobs. So seeing that, we work to, break or bridge those gaps that I just highlighted. So we've identified those critical things that we consider success factors that will help build capacity of governments for system strengthening. And those things, to reiterate, are, working to develop enabling policies, ensuring that governments have all of the policies and guides and the things to help, provide that legal backing and to push the work forward. We also try to establish strong governance systems to ensure that there is political will and that there are clear systems on how things are, governed or managed. We also work a lot in ensuring sustainable funding. So thinking of innovative ways to get governments to pay for their programs or to pull funds together so that work can be done in the health sector. And additionally, we focus a lot on helping to develop realistic plans and using rigorous prioritization skills and tools, and ensure that implementation of those plans are tracked aggressively, as frequently as weekly or even as daily in some cases, depending on the setting. And lastly, of course, we work to build the capacities of core personnel. So we try to equip them with all of the skills that they need, all of the tools that they require, and do this in a manner that ensures that we're checking frequently and that we are able to track and hold them accountable for the progress that they should be making throughout the process of the intervention. So now we're going to move into the second part of this conversation. And here we're going to be giving you examples of how we have applied that framework, or how we have instituted those success factors in the work that we do. Specifically, we're going to be using the example of the immunization program that I mentioned earlier in, excuse me, in northern Nigeria. Now, I'd like to paint you a picture of what the system was in northern Nigeria, or what the issue was in northern Nigeria before we started working there. So we had, there were 6 states in northern Nigeria that collectively I mean, before I even go there, I need to paint a picture of what northern Nigeria is, or, just to provide some context into what Nigeria or northern Nigeria is typically. So this is a region that is that has the highest population density. It has there's very high fertility rate. The people of that region are typically Hausa speakers, or a mix of tribes that are from the northern parts of Nigeria. They have certain cultural beliefs and myths that often limit demand and health-seeking behavior. There's also issues with very high rates of illiteracy and poverty, and just a lot of development issues in that space, as it were. Now, collectively, due to all of these reasons, naturally, they accounted for 5% of the world's unimmunized children as at 2012. So 6 states in Nigeria accounting for 5% of the entire world's unimmunized children. That's a lot of children there, just by the sheer population size that's there. I mean, that contributes as well. And also, at this time, in 2012, there were already polio eradication efforts that were going on in Nigeria. As you know, Nigeria has significantly struggled with eradicating polio and, getting Africa certified polio-free. So all of these issues collectively made it, evident that work needed to be done in those 6 states to help to improve child health outcomes. And the key bottlenecks that led to those bad outcomes were really, when we did the diagnostics, were really, poor or absent enabling policies. So there weren't really any policies that helped the system to move forward. There were issues with poor governance and political will. The leaders were not really plugged into the program, and did not even know or care about what was going on in their states. There were also issues with poor health infrastructure and utilities. There were issues with inadequate funding. Funding for health and immunization was very, very poor. There were issues with poor planning of resources and execution of plans that were managed to be developed. And lastly, again, there was poor capacity of government personnel. And we found that these things are kind of recurring. These were recurring things across all of the states, and across all of the other states and countries we've worked in. We found these sets of issues in varying degrees. So our work then was to help strengthen all of these system elements and build capacity to, ensure that the systems become strengthened, and that and that strength is sustained, so that the systems remain resilient and can layer on, for broader PHC services, while, ultimately helping to improve coverage and improve child health outcomes. So, I mean, now that I've laid the background for the work of the immunization work that we do in northern Nigeria, I will hand over now to Uche. Uche is going to be discussing specific examples of how we have applied or how we have tried to fix those success factors in the states that we work in. And yeah, over to you, Uche.
Thanks, Rai. Can you hear me clearly? Okay, great. So thanks, everyone. Thanks for participating. Just to highlight, please, as we go through the conversations, feel free to enter any comments, preliminary thoughts, questions you may have on the comment section, and we'll get to that as we go through. I don't think there's no need to wait, till the end. You can start to put in some of those now, and we'll get to them at the end. So, Rai, thanks for that introduction. I think you've done a great job of painting the picture of northern Nigeria in 2012 and 2013, when we started some of the work we do there to strengthen the immunization systems with support from the Gates Foundation and the Dangote Foundation, of course, working very closely with the government at the center, driving and doing that. I think as I go through some of these themes, which we've identified and, thought through over the years that we've worked in these clients to strengthen government systems, build them to be resilient, and establish even some of the systems now we're seeing that supported Nigeria with the Ebola response, has helped eradicate polio and getting Africa quite on the verge of getting certified in a few months, and is currently helping our COVID response, which is has been quite strong and off the ground, quite proactive. I'm going to go through specific examples of what we've done along these themes. Is in no way exhaustive. It's just some of the things we think are quite necessary, and I'll walk through that over the next 15 minutes. Just to highlight that the picture in northern Nigeria now, in terms of the outcome, things still look dire. But I think when you compare where we started from versus where we are now, there's a significant difference. Where you see process indicators in the northern Nigeria states are definitely much stronger than even a lot of the states you see in the south, which are typically more advanced, typically more economically empowered, typically has higher literacy rates and so on. So that shows a lot of things are moving in the right direction. I think ultimately for more recent surveys, we've also seen significant increase, sometimes 10, 15, 20 percentage points in the immunization coverage in some of the northern Nigeria states. A lot of the coverage rates are still not where we want them to be, but those are significant transitions that we've seen, which also help us to think that some of these themes that were put in place and we've reinforced over time, working closely with our partners and the government are working. So over the next 5 slides, I'm going to talk to specific examples of some of those themes. And then, of course, we'd like to hear from you, So on the current slide showing, slide 11, this speaking to enabling policies, which is critical, in our opinion, for sustenance of any transformation we wanted to do in the system. And for example, in the case of the northern Nigerian states, at the time of starting this intervention, there was really no platform or organization within each of the states that had full control of the PHC program, in which case the immunization interventions we're thinking about were owned and housed in different agencies, and that created a big issue with duplication, and nobody had absolute control. PHC staff across all the facilities were managed in some cases by the local governments, in some cases by the state governments, and even in some cases directly run by development partners which were not the government at all. So again, it became difficult to rally around a single plan that made everybody work effectively. The organizational structures for the primary healthcare development agencies, organizations formed to lead these were weak and really not driving some of those processes. So what was done? I think the important to highlight here is what the convening power of donors like the Gates Foundation and the Dangote Foundation was able to do in terms of bringing together the advocacy needed at all the national level, but at state levels, to be able to make some of the changes to the policies, and even sometimes required legislation to be passed to enshrine the full control of PHC in the state primary healthcare development agencies, which were the bodies that should have run that. This was directly in line with a national policy which we called PHC under one roof policy, that reinforced this and even established clear guidelines and scorecards to track transitions of states across getting to PHC DA that was strong and was running that. So with those interventions and the advocacy required, we made significant transitions. Having administrative control of the staff pushed to the SPHDA from whoever owned them. And of course, this was politically challenging in many instances. Programs that were typically run by many other different agencies, sometimes by the Ministry of Health, which was supposed to focus on policy, was also transitioned to the primary healthcare development agencies. Again, a lot of political issues with transitioning resources. But this was gotten done because of the strong convening power and advocacy which we had at the back. And ultimately, there was guidance from the national level, very clear on how the structures of the SPGA should be and the guidelines they should follow. So on the right, you see a chart that kind of demonstrates some of the changes that have happened in most of the states that have transitioned on the PHE under one roof scorecard. This improvement continues to go on, and a lot of these states are among the strongest in Nigeria's 37 states in terms of transitioning on the PHE under one roof policy. On the next slide, we showcase the example. Next slide, please. We showcase the example on the governance structures. And for the governance structures, we had a situation as well where in some of the states it was unclear who was managing or running or taking decisions on the programs. There was weak coordination, in which case many development partners did different plans, had different implementation approaches across the states, and this caused a lot of chaos and weak coordination. Also important was the political leaders were definitely not engaged, and health, and most importantly, immunization in this case was not a priority. Even though there was clearly established business cases for why spending little money on immunization had significant impact in the overall health of the population, but also the economy. So again, some of these were the issues. So again, with the convening power necessary, it was good to bring the government to the table. And in these specific instances, the interventions included having what we called biannual review meetings, where we even had Bill Gates join twice a year and has consistently joined in having conversations with this, and having the governors who led the states engage in those conversations. On the right, you see an example of the governor of Bauchi and the emir of Das at one of such meetings, where they engaged directly with the programs, understood the challenges, reflected on the results, and helped to push the primary healthcare managers to actually implement and get the job done. It was also a good avenue to get them to commit the resources necessary to getting some of that done. We also have a chart on the right hand that demonstrates clearly what the established governance structures were like for the immunization program. This was also transitioned from polio, and this was quite critical, all the way from the presidency of the national government to the states, where we had even the president and the state governors engaged in understanding where we were with the fight against polio, where we were with strengthening routine immunization, and now broadened to speak to PHC. These similar structures are also being leveraged even as we deal with the corona outbreak to make sure we have the leaders participate directly, the political will is there, and there's good coordination and accountability, not just the government, but all development partners working in the space. Slide 13 speaks to another example, which we have, that talks about the, one second. We're having some challenge moving the slides along. So on the sustainable funding, yes, thanks, Rai, for moving the slide. So on that, again, we had very big issues in northern Nigeria with funding, and of course, across the entire country. This was driven by some of the weak fiscal space, which we had in Nigeria at the time. There was also specific issues around non-establishment of budget lines for immunization, in which case there was really no legislated approach of getting funding for the program. Also, the financial management systems were very weak and caused a lot of leakage. In many instances, cash was disbursed directly from hand to hand. Of course, that caused a lot of leakage. So interventions here included working with the government, and this is where the private sector played quite a critical role, to develop and institute an innovative basket funding mechanism. That meant that the government and the partners put money into a pot, a direct account that was managed by the government with oversight from some of the development partners, like the Gates Foundation and the Dangote Foundation. And over time, made sure the funding responsibility was transitioned over a 5-year period to the states. In which case now, we have states like Kano, Bauchi that have been fully funding the immunization program over the last 3 years and consistently releasing those monies without default across all the states. So this made significant increase in the allocations of resources available to intervene in immunization programs, but also utilizing technology, we were able to get by some of the issues we had with the financial management and leakages, where electronic disbursement systems were instituted, bank accounts were used where available. In some of the other African countries where we're doing similar interventions is mobile money, which makes sure monies get directly to the hands of health workers that should conduct outreaches, that should deliver the services. And this has helped cause a lot of improvement in the programs. The next subject or theme that I would like to talk about as well is the robust work planning, which Rai already also spoke to. So on the slide as well, the issues there was a lot of the plans were overambitious. The budgets were not well thought through and definitely unsustainable. As well, many different partners had different plans. The government was never really in a position to understand who was doing what. So the intervention here was also using that platform to make sure there was synergies, that make sure there was one plan in the state, all inclusive of every partner providing any support. The plans were periodically reviewed. Prioritization was ruthless in some cases to make sure they were quite practical and things that were affordable. And the results were tracked and reprioritization done, as we moved through each year. So this was done on a quarterly basis, and these routines have been instituted and enshrined in terms of the way the states do things, that even without the interventions or support of technical partners, the states are already used to operating in these ways. The final theme I would like to talk about is the one on individual personnel capacity building. And the slide will come up shortly, but this is also very critical because we needed to have, or the states needed to have, the right people assigned to the right roles, and then making sure not just that the competencies were provided to those people and the clarity of roles, but also that they were well motivated. In many cases, we found that some of the challenges went beyond just the competence, but also in many cases, the behaviors were not as what was required, and the staff were poorly motivated for many reasons. Salaries not paid on time, job tools not there. There was really no autonomy in many cases, and bureaucracy frustrated even staff that were really interested in making a change. So what happened? I think one was to make sure there was clear definition of job roles, establishing some of the autonomy that was required for some of the managers across the different teams to make the immunization programs work. Next was the capacity building interventions for individuals, focused on adult learning methods. We focused quite a bit on what we call, or largely referred to as the 70-20-10 learning philosophy, that made sure there was little focus on classroom work or formal training methods, which is found is responsible for only 10% of the learning, but also a lot of focus on coaching and mentoring, which is the social interactions, which was responsible for 20%, but also making sure the experience or making sure the trainings and capacity building worked with the staff as they executed their job, which is responsible for the 70%. We've had significant traction in some of these where the capacity of people or staff working on the immunization programs are now being leveraged, pulled to other programs, and in some cases even pulled out of the government space, which is another challenge we're dealing with, to work in development partner organizations since they've been rapidly upskilled and have strong capacity. Also very important, and now speaking to the slide we have, was the approach of tracking the capacity transfer. We didn't just focus on increased knowledge or increase of skills, but actual execution of the actions or the tasks that the staff had. So this shows a simple rubric that we use to track and also create visibility around the capacity building interventions in the state, where we go from staff that don't conduct the activity. In many cases, what was responsible here was sometimes weak competency, but in some other times it was motivation issues and behavioral issues, where we tracked that staff conducted the activities with support partners, conducted the activities with some prompting, conducted it independently, and ultimately where we want to be and are getting to many of the states is that there is even backstop staff that can conduct this activity in the absence of the primary holder. In which case, even when the staff is pulled to another ministry, pulled to another program, or pulled even out of the government system, there was a plan for sustenance of some of those roles. So these examples touch on some of the key points that we've spoken to that are critical and were very important in the achievements we made in some of the states. I'll pause at this point and now hand over to Muyi, who will speak a little bit more in terms of coalescing some of these lessons we've learned, and then provide direct lessons for the COVID response that Nigeria currently has ongoing, and how some of these system strengthening interventions and themes that we've spoken to are what the country continues to build on, even as we respond to COVID, but also other epidemics that might come in the future. Thank you.
Thank you very much, Uche and Raihanah. Can you hear me well?
Yes.
Excellent. And thanks again, everybody, for joining. So I will spend the next 10 or 15 minutes really just recapping what we consider some of the most important lessons that we have learned through some of the work that Uche and Raihanah have spoken about. These are, again, not totally exhaustive. We try to highlight the ones that are more relevant to the conversation today, but also you will find that many of them have been touched on. But we thought it's a nice way to bring it all together as we segue into the conversation, the discussion part, where we can then brainstorm with you all how this may or may not apply to some of the work you do. So one of the first things to say is, like Uche previously mentioned, is the role of enabling policies. What we find working in a lot of environments with government is that, you know, the policy framework always sets the stage for what the government tends to prioritize. So Uche gave the example of the primary health care under one roof. He's described that in detail, but really putting that in place was able to empower the agencies in charge of the immunization programs and the primary healthcare programs broadly to focus on the program priorities. And, you know, so that mobilized the staff. They were able to commit resources. They were able to actually dedicate their time and bandwidth to it. So we find that consistently across board. That's always very important. And I think even when you bring it to COVID, you think about some of the emergency policy interventions of the government. So whether, again, talking about Nigeria, but I think all of you will be familiar with this at this point, whether it is the travel restrictions or even the emergency stay-at-home policies, those were able to push forward the agenda of social distancing and really limiting the transmission within the population. Another lesson that we learned is around accountability and transparency. And I think what's important to call out here is that, you know, most often we think about how do you hold the government accountable for their resources, for their activities and their deliverables to their citizens. And that's well in order, especially where you have some less sophisticated governments. However, what we also found is even the partners of the government are often not as accountable as they need to be. So one of the things that the accountability frameworks and mechanisms that we've facilitated in a lot of the work that we're doing is really to say, you know, if you're a partner or an implementer that is supporting a government at federal or national or subnational or district at whatever level to achieve an objective, what is your responsibility there? And is it enough to say, well, we tried what we could, but, you know, we couldn't achieve results? How do we make sure that we have a shared accountability? And we're seeing that movement, and that's really impacting the results. Uche spoke quite a bit on the issue of engaging political leaders. We talked about how at the highest level in some of the states, we had governors, and where we've worked with line ministries, we try to make sure that the political and administrative heads of the line ministries will be involved. So that's the cabinet minister or a commissioner if it's at the state level. And the reason for this is, of course, we all know the importance of the political will, but also with political will comes the ability to commit government resources. And again, speaking to the next point, which relates to the innovative pool fund mechanism, what we found is that when government puts its own resources into a program, the ownership is there, the commitment is there, they own the outcomes, they hold themselves a bit more accountable, but they also push their partners because they're spending public resources for it. Again, talking about the use of technology, Uche gave the example of the electronic transfer mechanisms that we put in place in many places, and these serve the purpose of, one, again, the speed of execution. So it used to be that funds will move from step to step, from national to state, from state to local government, from local government to health facility, and there was a lot of delay. There was also a lot of leakage along the way. But the direct transfers, whether we were using mobile money, whether we were using other platforms, depending on the context, really helped that. But also for reporting back, so using the mobile technology to report back expenditures, to account for the money, has a significant role to play. And I think one of the issues that we continue to find is that while the mobile technology penetration in our environment is pretty high, in some places as high as 80–90% of the population have access to mobile technology, definitely those are not, they're still underutilized in programming. One of the most important things perhaps that we learned doing this work is the issue of the individual staff performance. And Uche mentioned this, but we went into this like most, thinking that often that if people weren't doing a good job, at least a big part of that was that they didn't know what to do. But we learned very quickly that that was not necessarily other issues, contextual and behavioral matters that hindered people's ability to be effective on their jobs. And oftentimes, the term that we used was basically, that it was difficult to wake somebody up who is pretending to sleep. That became quite popular in the context of our work. And we found that really focusing a bit more on some of those motivators, whether intrinsic motivators or extrinsic motivators that come from the environment and the enablers of the work, really moved the needle. Again, talking about the learning techniques that we used, I think Uche spoke about the adult learning techniques, but again, what I want to say is the targeted nature of it. So typically, most training programs will pull a group of people and put them through a somewhat comprehensive learning program. And what we found, again, was that that was a lot less effective in the context of people who are working in development, because they are adults, and that we found to be more useful for learning basic things. But more often than not, we made a lot more progress when we focused on what specific needs that this person had, what skills did they need to do their specific job. So is it data analysis, is it communication, is it vaccine management, whatever it was, that was their job. What were the specific skills that they needed to be effective in that? And as we were building their capacity in those, they were able to apply it on their job. We found that went a lot further in terms of improving the effectiveness of the people. Can we move to the next slide, please? So the next slide so the next slide is here. I think that, like my colleagues have said, a lot of these things, many of them have now been pivoted, if you will. Some of the resources, some of the capabilities that we built have been pivoted to support the COVID response. One of the things, for example, is that through the polio eradication work, but also the Ebola response a few years ago, national and state emergency operating centers, which are essentially control towers where you have people who are only 24 hours, tracking the information, figuring out what's going on, responding, deploying responses and tracking responses and adjusting as necessary. Basically like a control tower. They were established, and those really have helped Nigeria's response over the last several weeks to the COVID outbreak. I think just being able to up and go were very, 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 very useful, and made not just Nigeria, but we found that a lot of the other countries that had to contend with Ebola had that experience and were a bit more ready to go with some of the basics of epidemic response. Yes. Also, the fact that there were dedicated funds in programs, whether it is polio, whether it's primary health care, those were able to be reprogrammed very quickly. And so while the governments now are working to raise additional funds for the COVID response, I think just money that is already available, people, skills, workers, frontline responders have been repurposed. One of the interesting things that have also happened is the speed and scale at which the private sector has been able to respond in the context of Nigeria specifically. And this built on the Private Sector Health Alliance, which was established a while back, really targeting, again, maternal and child health and primary healthcare broadly. And the Private Sector Health Alliance was established really to mobilize private sector resources, both in terms of money, but in terms of their capabilities, whether it is communication, whether it is logistics, to supporting primary healthcare and improving health outcomes in the country. So when COVID came along, this platform was very quickly able to galvanize leaders in the private sector, and it's been incredible, actually, the extent to which they have been able to rise up to support the government. So one of the things that also has been really helpful is that the plans, because the states and the federal government through the National Primary Healthcare Agency had a significant amount of experience developing response plans to polio, developing response plans to other outbreaks. We have Lassa fever, we have yellow fever, we have all of that. I think it was very easy to articulate a plan that was simple enough, but also to identify what resources were needed and to deploy them. And we already spoke a little bit about the emergency operating centers. And again, those have been deployed, but also they are staffed primarily by government people. There are partners. There's WHO, there's UNICEF, there is the SCIDARs that are supporting that effort, but primarily the leadership and the bulk of the staffing is really by the government. And those are really now managing the response to COVID. I'm going to pause there and leave the rest of the time to really discuss a little bit. I think I will hand it back to Raihanah, my colleague, to facilitate the discussion. Over to you, Ray.
Hi, thanks Uche, and thanks Muyi for helping to paint that clear picture of what the transformative interventions were that we put in place and the lessons we've learned from them. So we'll go on now to take comments and questions. Specifically, we would like to throw a question out there. Can you share experience, or what experiences do you have from your own work where you have used similar methods or models to help address some issues in human development? I mean, specifically in similar contexts in low or middle income countries. I mean, this could be around education, agriculture, economic empowerment, or even health that's different from our work, or but using similar models. So we have some questions that have come in before now. Please feel free to put in your comments, your questions, or suggestions, or resources that you might want to share with us on this topic in the comments or in the chat section. Kenneth, we have some questions.
Hi, Raihanah, are you still there?
Yes, I am, Uche. Can you hear me?
Okay, go on. Yes, we can hear you now.
All right. So, Kenneth, could you please take some of the comments or questions that we've gotten in the chat and read them out so we can have them answered.
Okay, thanks, Rai. Can you hear me?
Yes, Kenneth.
Okay. So we have a question around whether the technological solutions we used for financial management were previously existing or whether we had to develop those. There's another question around how we got the private sector to form a coalition and donate about $41.7 million. Akari Way wants us to speak more about the basket funding strategy. Olamide wants to know how our capacity building approach has managed to be effective despite the limited number of staff we typically have in the health space. So those are all we have now. We encourage you all to please ask more questions and we'll take those as we go.
All right, so I'll throw the funding. We have 3 questions on funding to Uche. Uche, shoot.
Yes, so I can address the basket funding and the question on the technology solutions. I'll let Muyi speak to the private sector. So basket funding mechanism is one, from the term basket, is one where an account is established that different players or stakeholders can put money into that and is for a specific purpose. So in the case of the immunization program, it was an account established by the government with contributions directly from partners, Gates Foundation, Dangote Foundation, and even more recently, UNICEF is putting money into those basket funds. And then the state is required to also put in counterpart contribution. The account, however, is owned and managed by the government, with the partners providing oversight. What that does is it increases the transparency for the funding within the system, while also strengthening the government's ability or capabilities to manage the funding and strengthen that financial management. It also served as the mechanism by which funding responsibility was transitioned to the government. So it's been critical to government taking up funding for some of those programs. Regarding the technology solutions, no, nothing bespoke was built. A lot of what were enshrined were things that already existed. Bank accounts were already there. The program didn't do that.
I'm using my phone. See, I'm in a meeting.
The mobile money in cases where that's available were not introduced by the programs. I think it was just the will of the government and the partners to put more transparency. And they're looking to what were those best options available that were available and down level what the health workers could use and simple enough. And then those were leveraged for the program. So none of them was bespoke. They already existed and were just leveraged for the program. So Muyi, can you speak to the coalition of the private sector for COVID?
Absolutely. So this is one area where when you say that system strengthening actually does play a lot to emergency response, this is one typical area. So let me give a little bit of context. Again, I spoke about the Private Sector Health Alliance. So it used to be up until around 2014 that, the public sector in Nigeria, again, as in many low middle income countries, was primarily responsible for social services, including primary healthcare. And it just did its own thing. Lots of issues with it, lots of effort. Quality issues, access issues, inequality issues. The private sector also played, because of the population and because of the economy, especially in the urban cities, the private sector had a major role just in terms of service provision, but it was very fragmented, it was completely disorganized, poorly regulated, and also had its quality and accountability issues. And both didn't speak to each other. But more than that, there were lots of big corporations and big businesses, continent-wide, some are even global businesses, that are operational in Nigeria and had a lot of competencies that could really help the health system. So in rural areas, for example, where there were power issues, there are telecommunications companies that had mechanisms to supply uninterrupted power to their telecommunications masts. And these masts often were in the proximity of health centers that then did not have power to supply their refrigerators where they could keep vaccines and other refrigerator-dependent products. So the government at the time, the National Primary Health Development Agency, the Ministry of Health, and a few of us that support them came together and said, how can you create a platform where you can bring together major private sector partners and one, sensitize them about healthcare and know that you don't have to be a healthcare company for you to support healthcare. And it's not always about cash. Sometimes it's about your technical competency. So the Coca-Colas of the world that really understood the supply chain to the last mile, the telecommunications firms of the world that really understood how to deploy technology to do things. How do you bring them on board? You had logistics companies that had trucks running around the country and that saying, look, how can you use this to distribute products? So what that did then was it became a platform, and all of the major players became members. We basically would meet every now and then, would discuss issues that were topical, and it was now almost like an engagement forum, which is what it is. So it was very easy when COVID came along for some of the business leaders to very quickly come together on that platform and say, what are we going to do? So you had the major banks, you had manufacturers, you had all of this, and they made commitments very quickly. And it's been very impressive actually to see to what extent they have executed against these commitments. Many of them, some give cash, some give in kind. So they would, again, contribute what aligned most with their core competencies. Where you had a cement manufacturer, for example, who's building isolation centers very rapidly. You have banks that are, giving cash to procure things and just those kinds of things. So it's that platform. It wasn't a new thing, but it already existed. People were already sensitized. Businesses had previously been sensitized to healthcare needs and the fact that it can be called upon to deploy their resources. And right now, in fact, I can tell you that at least in Lagos State, the government is saying, wait, let's prioritize what our needs are, and then you can step in, because the subscription to help is a bit more than even the government is willing to handle. Hope that speaks adequately to the question. Over to you, Raihanah.
Yeah, thanks a lot, Muyi. Okay. We have a couple more questions that came in, but we're really out of time. We're actually 1 minute to the end of the session. I'll just quickly answer one of the questions about what adult learning techniques that we used to build capacity. So all of the techniques that we use are mostly, as Uche said, on the job. So they don't require you to leave your point of duty to go to some classroom training or something to get, the skills that you require. We do on the job capacity transfer by helping you build the skills or teaching you the skills while you're applying it to a job function. We like to call that sometimes the see one, do one, teach one approach, where you observe me do it the first time, the second time you do the next one, and then the third time you're able to teach. But I mean, of course, the frequency differs from person to person, and these interventions are typically tailored to each individual's needs and their particular job roles or functions. We have other learning methods. We'll try to use the comment section just to answer some of the questions that have come in as well. We're really out of time, and we wouldn't want to keep everyone here beyond the hour. So thank you very much.